Thanks for joining us. My name is Jack Reichick, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought. We'd love to hear from you and get your questions and ideas and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started.
Welcome back to Pediatric and Congenital Heart Talks. I'm Jonathan Chen. I'm one of the co-executive directors of the Cardiac Center at the Children's Hospital of Philadelphia. And today it's my pleasure to introduce Dr. Andrew Glatz, who is one of our star interventional cardiologists and a clinical epidemiologist as well. Dr. Glatz began his life in Iowa, where he was a lifer going on to Princeton University to go on to medical training at Washington University in St. Louis, and subsequently his pediatrics and pediatric cardiology and interventional cardiology training at CHOP and the University of Pennsylvania. Our field is rife with the problems of children who are born with not enough pulmonary blood flow when they need it, and too much pulmonary blood flow when they don't need it. And from our field, from heart surgery, for 50 years, we've developed techniques and operations, and some of the first operations for the blue babies, that augment pulmonary blood flow. But these do require an operation, and they do have a significant amount of problems postoperatively. The cardiac catheterization lab is a place that has developed new techniques to provide these, avoiding an operation in the newborn period. And Dr. Glatz is going to speak to us today on catheter-based interventions to augment pulmonary blood flow. Andy.
Thank you, Jonathan, for that introduction. It's a pleasure to spend some time with you today talking about this topic. No talk about interventional techniques to augment pulmonary blood flow can be done without honoring the event that happened on November 29th, 1944. This is the iconic Blue Baby operation during which Alfred Blalock performed the first systemic to pulmonary shunt to relieve cyanosis in an infant with Tetralogy of Flow. Vivian Thomas can be seen over Dr. Blalock's left shoulder, helping him through the procedure. Despite how long ago this was done, the Blalock-Thomas-Taussig shunt has really remained the gold standard by which we can augment pulmonary blood flow for cyanotic neonates and infants. And despite its long and impressive track record, there are some limitations to the BTT shunt. Data from the STS database shows that this is actually one of the most morbid and mortal neonatal procedures, really after only the stage 1 Norwood, with a 7.2% discharge mortality and a 13% composite morbidity, with some high risk groups being identified. Our own experience at CHOP has shown that the BTT shunt is also not perfect, with a nearly 10% risk of shunt reintervention. Patients who require shunt reintervention have a number of worse outcomes. So in that context, the appeal to develop a less invasive alternative transcatheter option is clear. Theoretical benefits of a transcatheter approach to accomplish the same thing as a BTT shunt are reduced exposures to various neonatal noxious stimuli, including bypass, anesthesia, and various ICU morbidities. And importantly for the surgeon, when the patient comes back for either their complete repair for 2 ventricle circulations or the stage 2 for single ventricles, it's the first sternotomy. And in fact, if you count the stages of single ventricle palliation by the number of sternotomies, the stage 2 can actually become the stage 1. So broadly speaking, there are a couple different categories of transcatheter options to augment pulmonary blood flow in cyanotic neonates and infants. Broadly, there's right ventricular outflow tract interventions, including balloon pulmonary valvuloplasty and right ventricular outflow tract stenting. And then there's PDA stenting. And I'll talk about these 3 things over the next little bit. So we'll start with balloon pulmonary valvuloplasty. This is somewhat of a niche intervention. It really requires the right anatomic substrate for this to be effective and durable. These echocardiographic images are of a baby with Tetralogy of Flow and severe pulmonary stenosis. And what is important about this is that the right ventricular outflow tract obstruction is largely valvar. You can see on that RAO projection on the left of the screen that there's a reasonably open infundibulum, it's a reasonably sized valve annulus and a decent MPA, but clearly a valve that does not open well and is probably at least bicuspid. So this is a nice potential patient who could respond well to balloon pulmonary valvuloplasty. And when we put color on, it sort of reinforces the same findings that the acceleration really begins at the level of the valve without a lot of obstruction below the valve. So this patient went to the cardiac catheterization lab. This first angiogram in the right ventricle shows very similar findings as to the echocardiogram with a relatively open infundibulum, a decent-sized valve annulus, an MPA, but somewhat thickened leaflets that do not open well. So this is balloon pulmonary valvuloplasty being performed on the right. You have a nice waist on the balloon that resolves at peak inflation. And this did very well for this child, and saturations increased and was able to go home and come back later for full tetralogy of flow repair. A few years ago, we described our experience with this somewhat niche intervention. There was 16 infants with valvular pulmonary stenosis and a large VSD. They're primarily Tetralogy of Flow patients. Oxygen saturations increased in all. 2 of the 16 did require an early reintervention, and that is the Achilles heel of this procedure. That there may be not ideal durability in some situations. But the rest did have a durable response and were able to delay definitive surgery for a median of approximately 4 months. The Congenital Cardiac Research Collaborative is a collaborative I've involved with. I'll talk a little bit more in detail about later, but we're currently in the midst of doing a study on symptomatic neonates with Tetralogy of Flow. This is collecting data retrospectively across 9 different centers. One of the ancillary studies is to look amongst this group at patients who had balloon pulmonary valvuloplasty. There were 47 neonates across those 9 centers. And I'll draw your attention to this sort of cumulative incidence function curves at the bottom here. The red section shows the patients who required either a reintervention or early complete repair, meaning a complete repair that happened within 30 days of the balloon pulmonary valvuloplasty. This was nearly 40% of the cohorts. This is what we consider a less than durable procedure. So in some situations, we don't have the luxury of just dilating the valve because in many of these neonates, obstruction is multi-level. Here's an example of a patient with Tetralogy of Flow, severe pulmonary stenosis, who's got both infundibular narrowing, annular hypoplasia, and hypoplasia of the main pulmonary artery. You can see color acceleration beginning well below the valve. In these neonates, balloon pulmonary valvuloplasty is probably not really a reasonable option, but right ventricular outflow tract stenting is. And so that's what was done here. Again, a right ventricular angiogram shows multiple levels of obstruction. The lateral view on the right, you can see how narrow the infundibulum gets, with additional narrowings at the level of the valve annulus and the main pulmonary artery. Like balloon pulmonary valvuloplasty, this is a fairly straightforward intervention. It can be done from the right femoral vein. Here, 2 balloon expandable stents have been placed across the outflow tract that brought back into the right ventricle enough to cover the area of infundibular narrowing with a nice result. Probably the best, at least published, most comprehensive experience with right ventricular outflow tract stenting comes from the group in Toronto. In this paper from a few years ago, they reported on 42 infants at their center who underwent right ventricular outflow tract stenting, and they compared various details and outcomes of that group against comparator groups, including an early primary repair group and then a sort of more elective later primary repair group. RVOT stents, of course, were not done randomly. Patients that were referred to that intervention tended to be patients who had risk factors for primary repair. They did report a pretty durable outcome after RVOT stenting, and importantly, they demonstrated catch-up pulmonary artery growth. So this cohort tended to have small pulmonary arteries at initial intervention, but by the time they came back for their complete repair, their pulmonary arteries were similar in size to the patients who just underwent elective later primary repair. And at the time of complete repair, their clinical outcomes were similar. So this is encouraging. overall, to summarize the right ventricular outflow tract interventions, the pros would be that you're providing more physiologic pulmonary blood flow without a diastolic runoff. This may encourage better pulmonary arterial growth because of pulsatility. And from a technical standpoint in the cath lab, this is a relatively straightforward procedure with access from the femoral vein. The cons of this approach are you really need the appropriate anatomy, particularly for balloon pulmonary valvuloplasty, as I discussed. For RVOT stenting, you can do this in pulmonary atresia as long as there is a connection between the infundibulum and the main pulmonary artery, so you can reestablish continuity, but those are technically demanding procedures. So you really do still need essentially some degree of antegrade pulmonary blood flow, so not an option for all patients. There are questions about durability, particularly for the balloon pulmonary valvuloplasty patients. And importantly, having a stent in the right ventricular outflow tract may complicate the subsequent surgical repair and essentially obligates patients to a transannular patch. So you cannot have a valve-sparing repair after an RVOT stent is placed. So that's led folks to look for alternative interventions. PDA stenting has become very popular across the community over the past decade or so. It was actually originally described as early as 1992. That was the first experience in humans. And since that time, there have been numerous reports that speak to both the safety and the efficacy of PDA stenting. In ideal circumstances, this is a very straightforward procedure. This shows on the left panel there a relatively straight horizontal PDA with a nice little waist in the middle that you can anchor the stent. In this case, the stent's deployed from the femoral artery. It's really very straightforward to deliver a stent to this position. And then on the right panel there, you can see a pretty nice result with a stented ductus arteriosus. So in those circumstances, it seems like quite a reasonable approach, given that it's less invasive. In the early days of PDA stenting, there were a number of single-center studies that try to compare the outcomes of PDA stenting to surgical shunts. These were all relatively small series, single-center without really any balance between the patient characteristics in the two groups. Over the last couple of years, a couple of new studies have been reported. This is the research collaborative I mentioned earlier. At the time of a study that we did on ductal stenting versus surgical shunts, we had 4 participating centers. The CCRC has now grown to 9 centers for their Tetralogy of Flow study and is actually now at 12 for our upcoming projects. So going back to our PDA stent versus surgical shunt study, as I mentioned at the time of the study, we had 4 participating centers, which included 106 ductal stent patients and 251 surgical shunt patients. This was a retrospective cohort covering the period of time between 2008 and 2015. And because of the size of the cohort and the fact that we had patients from multiple centers with some practice variability, we were able to compare outcomes between these 2 treatment groups with some propensity score adjustment to try to balance some of the risk factors between the groups. So we were able to balance for center, single ventricle status, the presence of antegrade pulmonary blood flow, the underlying anatomic diagnosis, and some markers of pre-intervention illness, including inotrope use and ventilation. Our primary outcome was freedom from death or an unplanned reintervention to treat cyanosis. You can see the survival experience of the 2 groups. The PDA stent group is in the orange and the BTT Shunt group is in the black. Overall, the experience avoiding death or unplanned reintervention did favor PDA stent, although after a propensity score adjustment, this difference was not statistically significant. So the experiences were really equal. However, for a number of other secondary outcomes, we did see some benefit from ductal stenting. The adjusted differences in ICU and hospital length of stay favored ductal stenting. And then at the time the patients came back for complete repair or Glenn, the pulmonary arteries were more symmetric and larger in the ductal stent group. We also saw adjusted differences in procedural complications and the need for diuretics at discharge from the initial hospitalization, again favoring the ductal stent group. One potential Achilles heel of ductal stenting is there is a difference in overall reintervention. So this is cumulative incidence function on the bottom, shows all reinterventions other than the unplanned ones to treat cyanosis. Again, the orange line is the PDA stent group. So there's a real reintervention risk here, which we can talk about later, whether that's actually a negative or potentially even a positive. Importantly, in that same issue of Circulation, another multicenter retrospective study looking at the same comparison of ductal stents and surgical shunts was also published. This was a study from the United Kingdom that included 9 centers that participate to a UK congenital heart disease audit. They included 83 PDA stent patients and 171 surgical shunt patients between 2012 and 2015. Similar to the CCRC report, they used propensity score adjustment methodology to compare outcomes. Their primary outcome was survival, and they actually found a significant difference even after adjustment, with the hashed line at the top being the ductal stent patients who had a better freedom from death experience. They also demonstrated that ductal stent patients had shorter length of stay and an overall lower risk of requiring ECMO support. But again, there is this reintervention difference, and particularly if you look at the early freedom from reintervention, you can see that favors BT shunt patients. From our CCRC cohort, we've been able to do a number of ancillary studies to dig deeper into some of the important differences between these treatment options for various subgroups. We were able to link our cohort to FIS data, which allowed us to calculate hospital-associated costs, both during the index hospitalization and the first year of life. Overall, we showed that there was an adjusted cost differential that favored ductal stenting in the first year of life at approximately $35,000. This cost benefit seemed to be largely driven by the shorter hospital length of stay, which meant that your lab costs and your room costs for those patients were less. One of the questions that always comes up is ductal stenting as good as surgical shunt for single ventricle patients? So we looked at a subgroup of our overall cohort who had expected single ventricle anatomy. That included 35 ductal stent patients and 136 surgical shunt patients. And we showed that there was equivalency between the two groups in terms of interstage mortality, their hemodynamics at the time of the Glenn, pulmonary artery growth, and then the post-Glenn hospital course. That survival curve shows the transplant-free survival experience, which was equivalent. Again, though, the freedom from reintervention favored surgical shunts. We also looked at a subgroup of patients who had sole source pulmonary blood flow. So this is patients with some form of pulmonary atresia, where the PDA stent is the only source of pulmonary blood flow. This is a potentially higher risk group that does cause some concerns for some people. In our cohort, there were 35 ductal stents and 156 surgical shunts in that subgroup. And again, we saw equivalency in a lot of important outcomes, including mortality, procedural complications, and pulmonary artery growth. That's the survival curve there on the left. And then again, as we've seen in other subgroups, there is a higher reintervention risk after ductal stenting. So that angiogram I showed earlier showed a very nice straight horizontal PDA. Unfortunately, they don't all come like that. There can be an enormous amount of anatomic variability and complexity for ductal stenting. We described 3 different types of anatomic complexity based on the curvature or tortuosity. This is called the tortuosity index. A type 1 is relatively straight. Type 2 takes a single sort of gentle curve in the mid portion, and then a type 3 takes a number of curves. Nearly half of the ductal stent patients in our cohort were either a type 2 or type 3. So we have shown that this can be done safely and effectively, but as you increase tortuosity index, we also demonstrated there will be a higher risk of jailing of a pulmonary artery, a need for a reintervention, need for surgical PA-plasty at the next operation, but no difference overall in pulmonary artery size. So the question that comes up a lot is, can or should all ducts be stented? This is a patient with Tetralogy of Flow pulmonary atresia who has a left duct off the right arch with mirror image branching. It's a long, curvy duct, and you can see on the panel on the right that the stent has taken the shape of the ductus, and so we have this sort of C-shaped stent. That doesn't always happen. And here's another example of a patient. So this is a lateral angiogram. This is a very tortuous ductus. You can see it sort of looping and making another C-curve. But here in the right panel, when we've stented it, it's now assumed a straight configuration. It's not always easy to predict exactly how a stent's going to behave in a tortuous ductus. We're trying to understand this a little bit better. We do a lot of pre-procedural planning with CT angiogram. This procedure Ductal stenting really requires a lot of pre-procedural planning, one of which is some imaging. This is a still frame from that PDA case I just showed you, and I'm working with Muda Gupta and Matt Jolly to try to do some 3D rendered modeling of ductal anatomy, calculating various center lines, various angles to try to get a better understanding of exactly how a ductus will respond to stenting. This will help both determining which access point to use as well as stent lengths and some expectation potentially of how pulmonary arteries will respond once the ductus has become straightened out. So hopefully more to come on that soon. The other technical modification that really has made the approach and the safety of doing these more complex ductal anatomies has been in terms of how we deal with access. Many of the tortuous ducts tend to be vertical ducts that arise from the underside of the aortic arch. This procedure is really better accomplished from access from above, either carotid or axillary artery access. This is what we call the flip position, where a patient, after they're intubated and positioned and the tube is secured by anesthesia, is flipped around such that the feet point towards the head of the cath table. This allows you to have the length of the table for all the wires and catheters that you need coming out of from carotid access. We've shown in our CCRC cohort that, particularly for more tortuous ducts, putting a patient in the flip position seems to have a real benefit on procedural time. All right, so getting back to can or should all ducts be stented, this is anatomy that has concerned us probably more than just tortuosity or a vertical duct. I'll just show you an important frame here. So this is a patient who went to the cath lab on prostaglandin. There's a vertical duct, it's relatively short, and then what you can see there is the native anatomic LPA, which is to the right of the ductal insertion. So the ductus inserts into the left pulmonary artery. There's a segment of left pulmonary artery to the right of the ductal insertion, which is very, very narrow. This is a concern for threatened isolated left pulmonary artery unless you stent across that region into the right pulmonary artery, which then intentionally jails the left. This is an anatomy that gives us pause and will often prompt referral for a shunt and PA-plasty instead. So overall for PDA stenting, I think the pros really come down to the fact that it's minimally invasive, and by that nature, it has less morbidity and potentially less mortality than a surgical shunt. I think often because ductal insertion is more central, I think you can often get better pulmonary artery and more symmetric pulmonary arteries. And then the other thing in terms of a reintervention risk is that a ductal stent's dilatable. So we can put a ductal stent in at 3 millimeters of diameter when the patient's 3 kilos, and then bring the patient back a few months later and make it 3.5 or 4 millimeters. Essentially, you get a titratable or growing surgical shunt. The cons of PDA stenting, it does sometimes require reintervention. As I mentioned, there's anatomic complexity that can make this technically challenging. This is a procedure that really is not for the faint of heart, particularly in patients with tortuous PDAs and pulmonary atresia, where often the ductus will straighten and spasm once you get the wire across, which is can be a very unstable situation. So this really needs to be done with a lot of pre-planning, with an experienced team, and with surgical backup, and really buy-in from the whole institution. So I've talked a lot about data that exists primarily through retrospective study, and we have limitations, particularly in regards to trying to understand the comparative effectiveness of ductal stents to surgical shunts. Despite our attempts to use propensity score, there still can be unmeasured confounding. And many of these studies really are looking at outcomes in an as-treated approach, meaning we're really only looking at patients who've had a successful ductal stent place, instead of an intent-to-treat analysis where a patient goes to the cath lab with the intent to stent the duct, and for some reason it's not done. Those are hard to sort of discern retrospectively, so we don't really know in a true intent-to-treat fashion how these treatments compare. And because the reports have been still from relatively small numbers of experienced centers, we don't really understand the generalizability and whether the outcomes of ductal stenting would apply for the wider community. So to deal with all of those issues, myself and some colleagues proposed a trial, which is called the Comparison of Methods for Pulmonary Blood Flow Augmentation in Neonates, Shunt versus Stent, or the COMPASS trial. This is being run through the Pediatric Heart Network. In addition to myself, my co-chairs are Chris Pettit, Jenna Romano, Jeff Zampi, and Sarah Pasquale. The goal of this trial is to randomize 300 neonates across 23 centers in North America with ductal-dependent pulmonary blood flow to either a transcatheter or PDA stent or a surgical systemic to pulmonary shunt. We'll block randomize both by center as well as single ventricle status. Our primary outcome is going to be a composite of mortality and severe morbidity in the first year of life. The components will include death, ECMO, and the need for an emergent reintervention to treat life-threatening cyanosis. We have a number of secondary outcomes, including days alive out of the hospital in the first year of life and global rank score. Both of these are potentially valuable outcomes that have not really been used in pediatric cardiovascular trials, and so we're going to explore their utility. We'll also be creating a companion registry, which will include capturing data on patients who are either eligible but not enrolled, or are treated with a form of palliation other than a ductal stent or surgical shunt. This will give us a really rich treasure trove of data on a nice cohort of patients. We're hoping to have our first patient enrolled this fall with 2 to 3 years of enrollment. And this, we hope will be an important study. This will be the first ever randomized multicenter trial that compares a transcatheter to surgical intervention for congenital heart disease. Thanks for your attention.
Andy, it's a terrific talk. And to quote my former colleague, Tom Jones, I see these procedures as being varsity sport kind of procedures. They're not for the JV team to be taking on. And I'll say I have angina watching you guys deploy multiple stents in the duct. We can come back to the COMPASS trial, but in surgery, as you know, there's been this, we talk about it as religion. It's really been more like the Crusades, where there have been some very stalwart proponents of, in particular for Tetralogy of Flow, of a shunt as the first intervention for a complete repair later on versus a complete repair in the newborn period. And one of the things that I've noticed as an outsider to the cath groups is that there seems to be not Crusades level religion, but there definitely is religion among different centers between those who like to first propose an RVOT stent and those who are ductal stent sort of advocates. Can you kind of contextualize for us why the religion on that?
Yeah, that's a good question. We've sort of learned this in the context of starting to plan and develop protocols for the COMPASS trial, because there are sites who say we don't do ductal stenting for symptomatic or cyanotic tetralogy of flow. We do an RVOT stent. I think that's probably more of a institutional decision and not a cath decision. I mean, I think if you asked interventional cardiologists which procedure they'd prefer to do, they would prefer to do an RVOT intervention. It's a little more straightforward. It's a little less sort of hair-raising than ductal stenting can be. But if the sort of center, including the wishes of the surgeons, is to keep the RVOT sort of untouched, then that puts us down that pathway. Now there are situations where you don't have the option, and so ductal stenting is really the only option. So centers still kind of dabble with both, but yeah, you're right. There is this cultural thing, but I think it's really driven by the cardiac center as a whole, and not just the interventionalists. We'll do whatever you guys want.
Do you think that'll contaminate the equipoise of a randomized trial like this? If you're at a center that doesn't do a lot of ductal stents, and the child gets randomized to that could be problematic, I would think.
Yeah, that's something we're very sensitive to. From an equipoise standpoint, the goal is to make sure that all centers at least have the notion that in a patient who's being considered for either ductal stent or BT shunt, that the center does not already believe one is superior to the other. So if your center just prefers to do an RVOT stent, that doesn't mean you've lost equipoise for those patients who are only eligible for a shunt or a ductal stent. So, I think we're okay from an equipoise standpoint. From a sort of an operator experience, that's important, and we've got a lot of measures in place to try to make sure that ductal stenting is going to be done as safely as possible, particularly in sites that don't have a great deal of experience. We've implemented a number of steps, including site visits. So we have some simulations with 3D printed models for tough cases. We'll have a case preview with an experienced group of operators that's required for the first 3 interventions, first 3 ductal stents at each site. And then we will require each site to have sort of a primary operator who will either perform or assist with every ductal stent, because, the last thing we want to do is do anything that would jeopardize patient safety.
You and I have talked a lot about this because, of course, Dr. Qureshi presented at the ATS the other CCRC study, which was looking at ductal stenting versus, stage repair, which included some ductal stents in patients under 2.5 kilograms. And the benefit that had been seen previously in the overall cohort related to things like lengths of stay were eliminated. And I think the speculation was that the relative prematurity or all the other problems that come along with a low birth weight baby will mitigate any sort of purported advantage. Do you think that's going to be a durable finding overall?
Yeah, I mean, I think anytime you start to include patients with significant risk factors for poor outcomes, regardless of the treatment strategy, you're gonna see outcomes that are driven more by the patient's intrinsic factors and less by the treatment strategy employed. You get around that a little bit with the trial because we exclude very high risk factors. So we try to generate a cohort of patients who otherwise we expect would do fairly well. I think the other issue that we have to think about, particularly in the study that you talked about, kids under 2.5 kilos, is if you narrow your view of outcomes to a fairly discrete period of time, either that initial hospitalization or the first year of life, you may not see anything. But we need to continue following these patients because maybe the benefit doesn't become evident until we start to look a little bit further out and we look at long-term outcomes where pulmonary artery size maybe is more a driver of long-term outcomes than sort of the short-term outcomes.
I think one of the fun things about our field is that although we're all in it together, I think our two individual areas, in particular the cath folks and the surgeons, challenge each other's dogma a lot. And so one of the things that ductal stenting in particular has always kind of challenged our dogma is that we grow up with this notion that the amount of flow you get through an aortopulmonary shunt is directly proportional to the aperture of the vessel from which it arises. And so that's why the theory, at least, is that you should have less of a risk of, say, necrotizing enterocolitis with a shunt that comes off the subclavian artery for sure, the innominate artery probably. And I've yet to meet an interventional cardiologist who likes us doing central shunts. And yet, one could make the argument that for a lot of these ductal stents, the ductus is essentially providing a central shunt. And I bring this up because I've noticed across many institutions that the pattern as you go toward the ductal stent is either the morning of or just as you're going to the cath lab, that they turn off the prostaglandin with the hopes that the duct will get smaller because it sounds as though that ductal size will, to some extent, dictate the size of the stent. So here's my question for you. So if you guys are going to challenge our dogma about amount of flow that goes through, and you may be right, the amount of flow that goes through being related to the aperture, why is it that we don't see more complications that you would think of if you were to put in a, say, 4 millimeter central shunt? We would never think of doing a shunt that size, and yet these ductal stents seem to do okay. Do you think it's the length of it? Is it a different technique?
Yeah, no, that's a good point. I mean, most ductal stents are really central shunts, although I showed the example. I mean, ducts can come off innominates and subclavians too, but I mean, I think as long as the interventionalist is sort of smart about it, we can compensate for that because, yeah, the flow is going to be dependent on both the cross-sectional area as well as the length of the stented ductus. So the tendency for most people who do this is to go smaller than you would with a shunt. So it's pretty unusual to put in a 4 millimeter ductal stent if it's coming off the aorta. So almost all of our ductal stents are 3 or 3.5 millimeters in diameter. The only time that I'll use a 4 was, for example, that case I showed because the stent it was so long and it came off the innominate. But otherwise, we do sort of, in deference to the notion of having more unrestricted pulmonary blood flow, go with a smaller diameter stent. And it's not always perfect. I mean, we've seen cases of patients who seem to have problems from overcirculation, but overall, in our retrospective cohort, if you look at diuretic use and other complications like NAC, it did not seem to be an issue. But yeah, you have to be in tune to that, and you can't just sort of blindly put in a 4 millimeter ductal stent in every position.
We always, I think our surgeons, we've pondered for decades why it is that we cannot make any impact on the operative mortality for aortopulmonary shunting across all cohorts. I mean, it's really essentially the same mortality it's been for 20 years. There is the thought that one of the most devastating consequences, as you know, is shunt thrombosis. And so with the advent of heparin-bonded Gore-Tex tube grafts and maybe ones that are balloon dilatable, perhaps that can get a little bit less. So talk to me a little bit about the COMPASS trials protocol for anticoagulation and how that impacts these babies.
Yeah, this is a really important point. I can say just broadly that acute ductal stent thrombosis has been reported. There are case reports. I've heard anecdotal stories. Fortunately, we've never seen that in the 100 or so cases we've done over the last few years. But acute ductal stent thrombosis can happen. So we do pay a lot of attention to anticoagulation both during the procedure and in the immediate sort of post-procedural period. The other thing that's important, though, is that later acute ductal stent occlusion just doesn't happen. I've never heard of it. We've never seen it. So you can send a baby home with a shunt, and there may still be a risk of the shunt acutely occluding at home a few weeks later, but that just doesn't happen with ductal stents. What happens with ductal stents instead is you get this sort of slow neointimal ingrowth, and maybe that's modified by the type of stent you can use. So you'll see a slow decline in saturation, but that's not a harbinger of impending acute stent occlusion. So we can, I think, sometimes maybe breathe a little easier about the long-term anticoagulation plan. What we're going to do for Compass is, we don't want to change people's practice too much or dictate practice. So we've set up a sort of a set of guidelines that we would encourage sites to use to try to maintain some consistency in terms of anticoagulation both during and immediately after, but not enforce that. It will not be a protocol deviation because many sites have their own pathway that they're comfortable with. But I think what most people do, of course, is full heparinization during the procedure, and then we usually keep the patients anticoagulated for 48 or 72 hours afterwards to sort of get you through that acute post-stent occlusion risk. And then they usually transition once they start feeding to some form of antiplatelet therapy, either mono or dual antiplatelet therapy. But again, it won't be mandated.
So one thing that our viewers may not know, Andy, about you is that you do lead the Cardiac Center Research Core, and you have a master's in clinical epidemiology. You may also be one of the smartest people I know, so that sort of factors into all of that. So a question for you as a scientist. So there's how do you balance research with your clinical activities? That's A. And the B is this may or may not be a connection. Parents sometimes will be flummoxed by the notion of the term catheterization laboratory. And was part of what drew you into cath because there is a laboratory scientific kind of aspect to it, right? There is a sort of data that you have, and not dissimilar to us in clinical medicine, but maybe with a more immediate sort of return on hypothesis. You have your hypothesis, you intervene, you retest. Was that what drew you into cath as a field? So A, how do you balance research? And the B is what drew you to cath?
Yeah. Thanks. I mean, I'm fortunate that my clinical work and my research overlap quite a bit, so I guess it's easier to balance if you can kind of sit more in the middle of the seesaw, and your time kind of contributes to both. I will say that cath, being in the cath lab appeals to my way of thinking. You've got numbers coming at you, hemodynamics, you have to think on the fly, things have to be very ordered and logical. And everything is reasoned out, and that did sort of appeal to the way I think. So that's really what drew me to the cath lab. I don't know if the word laboratory had a whole lot to do with it, but yeah, I mean it's a fun environment to be in. I mean, what's nice about being in the cath lab is for that few hours, you have one patient, and all of your attention and all of your focus, and I'm sure you can understand this, is on that patient, and you're not worried about the outside world at all, and that ability to focus for those few hours and think through a problem and try to solve it is really nice.
So if I remember this correctly, you not only spent time at Princeton, but some time at the Rockefeller, or at least you carry around the coffee mug to intimidate everyone that you spent time at the Rockefeller. So was that influential in your track of where you decided to go to in terms of specialty or research or?
Yeah, I sort of. So I grew up, my parents were both scientists at Iowa State University, and my dad was a chemical engineer, my mom was a microbiologist, so I assumed that I would be a scientist like them, and in fact I started at college thinking I was going to be a physics major, and the physics was fine, but the math was a problem. So I didn't even really understand. We didn't have doctors in the family, so it wasn't really until I was exposed to some of my friends who told me about this pre-med thing that I started thinking, oh, there's a way to use science as well. But I wasn't really, for a variety of reasons, wanting to start med school right away, and so looking for other jobs and maybe partially because I didn't want to disappoint my parents by not doing any lab work, I did spend 2 years working in a neuroscience and neurobiology lab at Rockefeller University, which probably has zero effect on the way I practice in the cath lab now, but certainly did a lot just for kind of intellectual curiosity and scientific process of type stuff.
Yeah, I don't know if I discount that. I mean, the Rockefeller probably has some of the largest concentration of Nobel laureates per square foot of university. That has such a small footprint, and yet every year there seems to be some Nobel Prize winning somebody who comes out of there. So tell me a little bit about Iowa. So I think of many of the greatest cath people I know, of which you would be one, but I've never asked you this question, as being somehow artists, visual artists in their other life. So some of my closest friends who are cath people are fantastic, for example, pro-am photographers, because I think they have, I can imagine when I see their photographs that these are the same kind of beautiful compositions that they're hoping to make with, say, pulmonary atresia mapkas, right? where you're trying to take something that's like completely bizarre and making it into something that is beautiful. And there's that silk purse sow's ear sort of adage. But do you have a visual artistry past that we don't know about?
I'm afraid I have to disappoint you, and not really. I must be the exception. I was a terrible artist. So I appreciate others' art because I just can't do it myself. I mean, I did, I guess, do some photography like we probably all did. And, when we're on a family vacation, I'm the one who takes the pictures because I can at least compose a better image, I guess, than my wife. But no, I somehow managed to stumble into the cath lab without those skills.
So if one were to say cath people are born and not, reared, right? So let's say that you're born with innate talent to manipulate wires and to have the kind of brain that wants to be in the cath lab. The counter theory would be that the place to be in some instances would be the adult cath labs, because industry moves at such a faster pace there. I mean, look at the evolution, as we heard from Matt Gillespie, right, of transcatheter aortic valves. Not even a twinkle in the eye 15 years ago. Mick Jagger gets one, 5 years ago and is off, rocking around the world. So why pediatric cath and not adult cath? Why pediatrics and not adult medicine?
Yeah, I mean, if you could do adult cath lab work without having to do internal medicine first, then maybe I would have found it. But you have to make that decision early on, and for me, pediatrics was always more appealing. I mean, how could you not try to work hard on behalf of kids? Most of the things that happen to them are through no fault of their own. With adult medicine, it's usually or often from bad lifestyle choices. So, the sort of motivation to work with children was always just much easier. Kids are resilient, they bounce back, all these great things that we always talk about. The understated or underappreciated driver for me was that I was disgusted by the toenails of sick adults in the hospital, which would kind of stick out from under the bed sheet, at the bottom of the bed. And so I didn't think I could do that. So I got diverted to pediatrics and
podiatry.
Yeah, that's right.
No podiatry, no adult medicine. Yeah, I can imagine that. Well, I think sometimes the analogy has been made in the past of Foucault's pendulum. That there's versions all around the world. The famous one I think is in Paris at the Pantheon, and it's one of these long pendulums that are in these huge rooms and they swing back and forth. And I think that if I remember the story right, they adjust for the rotation of the Earth, right? So as it keeps swinging and it swings in different directions because the Earth keeps rotating, and sometimes I felt as though our surgical, at least, futile undulations between stage repair to tetralogy and complete repair to tetralogy is missing completely the fact that the Earth is rotating around us. We're just swinging back and forth. There are proponents on each side. We battle it out in conferences every year, as we have for the last 2 decades. But all the while, stents in the ductus have come up, stents in the RVOT have come up. And so I have great admiration for you and the COMPASS trial investigators, because I think this is a much needed trial for us to. It's at least a first step, much in the way that SVR is a first step. It's not the be-all, end-all. It's probably going to raise as many questions as it answers. But at the same time, it gets us one step further from just constantly swinging back and forth and not noticing the passage of time. So thanks to you and to the investigators who are really pushing that forward.
Thanks. Yeah. Hopefully we can pull it off. Thanks.
So again, thank you for joining us for Pediatric Congenital Heart Talk at the Children's Hospital of Philadelphia.
Thanks so much for joining us. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.